All right, thanks for joining us this afternoon. My name is Dr. James Scott. I'm an adult reconstruction orthopedic surgeon over at Mercer-Bucks Orthopedics. And today we're going to be discussing hip arthritis, what you need to know about it, diagnosis, and the treatment options. Just as a sidebar, we have no relevant financial disclosures related to this meeting. Any of the topics or products, medications, or implants that we discuss, I don't have any financial discourse related to that. All right, so the purpose of this discussion is largely to discuss the common traits and findings of hip arthritis, discuss the scope of the problem, and the various treatment algorithms and options to limit pain, maintain an active lifestyle. So what is hip arthritis? Commonly occurs in older individuals. And when we say older, we're talking about over the age of 65. Older people are not the only ones that can be affected by arthritis. There are some other causes that can affect younger people, previous injuries or trauma, infectious, different inflammatory conditions like rheumatoid arthritis or lupus. There are some developmental anomalies, and then there's certainly hereditary causes associated with this. So what is it? A lot of the questions that get asked is, what's osteoarthritis and what is it? Is it something that's accumulating or depositing? It's really a degenerative cartilage disease that causes the healthy cartilage in the joints to start to break down over time. It's one of the most common forms of arthritis, and it's one of the leading causes of disability worldwide. If you look at the pictures on this slide, if you can see my screen, we have on the left, this is what a normal hip looks like, and this is what an arthritic hip looks like. And there are some subtle differences here. The arthritic hip doesn't look quite as round. There's not as much space here. Fairly advanced arthritis of the hip. And the question then becomes, is the hip joint the problem, or are there things around the hip that can be causing pain? So different sites and different areas can cause pain in and around the hip. The physical exam, history, imaging studies such as x-rays and MRIs can help localize the symptoms to help correctly diagnose the problem. I have a slide here demonstrating common locations of different areas of pain around the hip. On the left, hip joint pain is commonly pain within the groin. Pain towards the buttock or lower back can be indicative of sacroiliac joint pain or sciatica. And then pain on the outside part of the hip can be due to things like bursitis or problems with the muscles and tendons around the upper part of the hip called the hip abductors. Common symptoms of hip arthritis then. So stiffness. A lot of folks will complain they have a hard problem putting on their socks and shoes. Pain deep within the front or side of the hip or buttock. And that actually has a name for it. We call it the C sign. And this is a picture just sort of illustrating that. People kind of grab their hip and say, I'm not really sure where it hurts, just hurts right in here. Sometimes that pain can refer down the thigh to the knee. Patients will typically report some difficulty with daily activities, have pain with walking, worse if walking faster, for longer distances, or if the surfaces are hard or uneven. Patients may start to develop a limp to compensate for that hip pain. And positions where the hip is bent can sometimes be more painful, such as prolonged sitting or doing squatting maneuvers. Commonly, the hip can ache at nighttime or be accompanied by stiffness in the morning. And a lot of folks will report difficulty when rising from a chair. So our treatment algorithm begins with very simple, non-invasive to more complex and invasive. And we'll go through each one of these things and what our goals are. So we always start with non-surgical treatments. So patients that initially present with complaints of hip pain, after going through their exam, getting a brief history and reviewing any appropriate imaging, we start to talk about what are things that we can do to try and help mitigate some of these symptoms and make their life a little easier. So modification of activities. If there are certain things that are more provocative or uncomfortable than others, then we try to go about life and go about our day avoiding some of those things that can make the hip hurt more. Low impact exercise can be very helpful in mitigating some of the symptoms. So aerobic exercise, such as cycling, walking, swimming, or the elliptical, can improve long-term functional outcomes. One of the things that we talk about initially to help with pain in our lower extremities, especially our hips or knees, when we're talking about weight loss, we look at something called the BMI, or body mass index. What's considered a healthy BMI is generally 25 or less. BMI greater than 30, starting to consider overweight, and a BMI over 40 begins to associate with a significant increase in medical and surgical complications. And sometimes if the patient has a BMI that's over 40, corrective surgeries may even be not indicated or contraindicated and be considered too risky. Weight loss can decrease stress on an arthritic hip, which can help improve pain and help improve function and minimize the risk of needing more invasive treatments in the future. So some medications that we commonly use to help treat the symptoms of arthritis are nonsteroidal anti-inflammatories. Those are generally our first-line medications for mild to moderate symptoms. And these are medicines such as ibuprofen, naproxen, or diclofenac, which is Voltaren. And there are some prescriptions that you can get from the doctor's office, things like meloxicam or Celebrex. They can lead to a significant improvement in pain with use. Sometimes their use can be limited by other medications that some patients may be taking, such as anticoagulants, if they have kidney disease, or some certain gastrointestinal disorders. Acetaminophen or Tylenol can be a safe adjunctive medication to use in addition to anti-inflammatories. When used alone, they're less effective in anti-inflammatories. They generally have a better safety profile and are not limited by the use of blood thinners or kidney. There is the potential for liver toxicity if used in high doses or combined with alcohol. And finally, opioid medications are generally not recommended in the use of treatment for osteoarthritis. They are associated with problems of tolerance and dependence. Certain supplements that can be used to help with some of the symptoms for arthritis. Fish oil has some useful joint as well as cardiac and neural health benefits. You should always consult with your primary care physician before starting, as lipid profiles can be impacted by the use of fish oil. Turmeric is a commonly used food supplement that does have some anti-inflammatory properties. And probably the most commonly and well-known supplement is glucosamine and chondroitin. Unfortunately, studies have not shown any clinical benefit in patients with osteoarthritis of the hip or knee. And so therefore, we generally do not recommend starting these types of medications. As we move on from oral medications, there are some injectable medications that we can use to help decrease the pain associated with hip arthritis, and sometimes even help better identify potential sources in patients that have overlapping symptoms. So corticosteroid injections or cortisone shots are the most common types of injections that we use for hip arthritis. These are generally done with image guidance, such as an ultrasound or an X-ray, to ensure accurate placement of the medication. They can be effective for short-term pain relief and may be repeated as frequently as every 3 to 4 months. Viscosupplementation or hyaluronic acid injections are commonly used in treatment of arthritis of the knee. The use is considered off-label in the hip. It is not FDA approved for use in the hip, mainly because there are not any good randomized control trials of their use in the hip, and they are not covered by insurance. In folks that are not deriving relief from steroid injections and may have significant medical comorbidities that preclude the likelihood of being able to have an operation, then viscosupplementation may be a useful tool to add in our treatment. However, it is not one of our frontline treatments. And things that are under further investigation as far as their utility in the treatment of hip arthritis are things like platelet-rich plasma or stem cells. Now, if we've done the non-surgical treatments, we've modified our activities, we've been taking oral medications, we've done some physical therapy, had any injections, and the pain continues to progress and impair the quality of life, then we start talking about surgical options. And so when we're talking about surgical treatment of hip arthritis, we're looking to restore alignment, decrease pain, and improve overall function and quality of life. So as far as the surgical treatments, we have what are considered arthroplasty, which is replacement, and non-arthroplasty or non-replacement treatments. So the most common non-replacement type operation done for folks that have hip disorders is something called arthroscopy, but it does have relatively limited use. Typically, we would do this for folks that have relatively mild arthritic changes and additional problems such as a tear of the labrum, which is a fibrous ring around the socket portion of the hip, or if there are focal cartilage lesions. It's most effective if there are, again, minimal arthritic changes. The results start to decrease in patients over the age of 40, so they're not as, the outcomes are not as good in patients over 40. And if there are any structural changes or anomalies to the hip, then arthroscopy is really not indicated. When we're talking about arthroplasty, there's two types of arthroplasty treatments. One is hip resurfacing, which I'm going to touch on very briefly, and then I'll get into the major operation that we do, which is total hip replacement. So hip resurfacing is something that's an operation very similar to hip replacement. It's a little bit more bone preserving. It doesn't remove the femoral head and femoral neck. It's almost like putting a metal cap on the ball portion of the hip. And there's a socket similar to a total hip replacement. Some of the benefits, that's a very stable joint, a very low rate of dislocation. But some of the cons, it's the indications are more limited. Fewer patients fit the profile to have this type of operation. There are size restrictions. Patients that are on the smaller or larger end of the spectrum, we don't have appropriate sized implants for those types of patients. If there are any sorts of deformities or leg length discrepancies, those cannot be adequately addressed or corrected with hip resurfacing. And finally, the articulation is a metal on metal, which has been associated with some serious problems in hip replacement literature over the years. And for total hip replacement, these types of articulations have been largely withdrawn from the market. All right, so total hip replacement. This is the operation that we do most commonly for patients that have hip arthritis that has no longer been responsive to non-surgical treatment. It's one of the most successful procedures in orthopedic surgery with very high satisfaction rates. Over 96% of patients surveyed said that they would do it again, with an 89% overall satisfaction rate, and over 3/4 of patients feel that their preoperative expectations were met. The operation is very popular amongst our population, and volumes are continuing to rise year after year. As an example, in 2014, over 370,000 total hip replacements were performed, and that's estimated to increase to over 630,000 by 2030 and over 1 million by 2060. So again, indicated for end-stage arthritis, failure of non-surgical interventions, and the patient should be relatively healthy with stable medical conditions. So doesn't mean the patients have to be without medical problems, but things like diabetes, heart disease, hypertension should be well controlled and well managed and have close follow-up with their primary physician. And the x-ray on the right is just an example of a patient with a particularly severe arthritis affecting both hips. What the procedure does is we're removing diseased cartilage and underlying bone and replacing it with components largely made up of metal and plastic. And this is that same patient after she's had hip replacement of both hips. So total hip replacement is considered the gold standard of advanced hip arthritis, with a proven long-term survivorship of over 90% after 15 years, with a greater than 90% satisfaction rate. There are some limitations. There is a need to modify activities, high impact type activities that involve running, jumping, or collision type sports should be avoided to minimize the risk of injury, number one, but also damage to the underlying components. Again, this is the image on my screen is just pointing out the major components of a hip replacement when we're looking at an x-ray. In the acetabular component or the cup, you have the bearing surface, which is the metal or ceramic ball and plastic liner, and the femoral component, which is called the stem. Now, there's different approaches to do a hip replacement, and some of the most commonly asked questions is, how do you do it? Which direction do you go? And so we have several different ways to essentially do the same operation. We have what's called the posterior approach, the direct anterior approach, anterolateral approach, and direct lateral approach. These are the four most common ones currently being done in the US at this time. So is there a right way? There's really not a right way or a wrong way. As far as the different approaches, there's really no differences in the short-term outcomes, meaning 3 months, or long-term outcomes, meaning greater than 3 months over 5, 10 years. Patients essentially do the same no matter which way the hip is approached. There are minimal differences in immediate postoperative pain, limping, time to discarding canes and walkers, and overall satisfaction. And I would end with the best approach is the approach that the surgeon is trained on and most comfortable with. So the decision has been made to proceed with surgery. What are things that need to be done? So folks are getting ready to move forward with arranging a hip replacement. We have a couple of clearances that need to be done. First things first, we have patients go see their dentist and make sure that if there's any potential problems in their mouth, that those are addressed in advance. The mouth, and people ask, well, why do I need to see a dentist? The mouth can be a source of bacteria and infection, and we don't want you to get an infection in your mouth that could potentially lead to an infection somewhere else in your body, and for our purposes of this talk, in your hip. So minimize the risk of infection associated with your oral hygiene. Medical clearance. So alluding back to the concerns of different medical problems, we have patients make an appointment with their primary care physician to ensure that their underlying medical issues are in fact stable and that there aren't any adjustments that need to be made to medications or diabetic regimens, etc. If patients have some underlying cardiac problems, a history of heart disease, or if there's any abnormalities identified on preoperative screening, such as an EKG, we would have the patient see a cardiologist to ensure that they are in good heart health to undergo an operation. Sometimes preoperative physical therapy can help improve conditioning, range of motion, strength and balance. And sometimes hip arthritis can be quite debilitating, and patients can get quite deconditioned in advance of surgery. And so some preoperative physical therapy can help improve that conditioning, which can make the postoperative recovery a little bit easier. So historically, hip replacement was associated with a long recovery and long hospital stay. So over the last 20 years, hospital stays have gone from over a week to approximately 2 days or less. We've had a greater emphasis on rapid recovery protocols from anesthesia, intraoperative pain management, as well as physical therapy, which helps result in earlier mobilization and subsequently early discharge. Same-day total hip replacement is now becoming widely accepted, and new protocols are in place to help ensure that we can safely employ and execute this process. So historically, again, the hip replacements were only done in the hospital. Now that's no longer the case. We could do hip replacements on an outpatient basis and even do hip replacements in the outpatient surgical center. After discharge from the hospital or surgical center, patients will typically have some therapy at home for about 2 weeks, followed by some outpatient therapy for about 4 to 6 weeks. And the duration of these timelines will vary from patient to patient, depending on what their needs are and what their preoperative status was. Physical therapy for hip replacement is much less rigorous than physical therapy done for knee replacement, with primary emphasis on walking and balance. Patients are seen in the office in 2 weeks after their surgery for a wound check. Sometimes if sutures or staples are in place, then those would be removed at that time. Patients typically are cleared to drive in about 4 to 6 weeks, depending on whether or not they're using any pain medications and how well they're getting around. Typically, we get x-rays at the 6-week office visit, and a typical time out of work is somewhere between 6 and 12 weeks, but that can vary based on the patient's occupation. Things to help make a good operation better. So we talk about technology, some things that are constantly being improved. So they help tools that are help improve accuracy, hopefully improve long-term outcomes. Things that have evolved the most over the last 10 to 15 years have been improvements in materials, making more durable bearings, plastics that last longer, ceramics that last longer, that are less biologically active, that lead to fewer problems with loosening and implants wearing out. Other tools to help with placement of implants, such as robotics, navigation, and augmented reality, which is on the horizon, have been used to supplement traditional surgery, but have not replaced traditional surgery. But they have certainly a role in more complex situations. And finally, I'm going to end there. Commonly asked questions that I get in the office all the time. When is the right time for a hip replacement? What I try to counsel patients on is that there's no right or wrong time. Patients generally know when their symptoms and their disability and compromises and things that they like to do, want to do, have reached a point where they don't want to deal with that anymore. Medications aren't working, therapies aren't working, and they're ready to move on with their life and try to regain some of the ability to do some of the things that they enjoy that they've lost over the years. Can you wait too long to have a hip replacement? You generally can't wait too long. I have yet to see a situation where your arthritis has progressed to the point where a successful hip replacement or reconstruction could not be performed. As far as expected longevity of a hip replacement, as I alluded to in earlier slides, we expect 95% of these devices to be functioning well without a problem for over 10 to 15 years. And with the emergence of better materials and better bearings, we expect them to generally last longer in the future. But based on current data and outcomes that we've been gathering since the early 2000s, we have a very high expectation that the majority of these implants will be well functioning for at least 15 years. So can I play golf or engage in other activities or sports? And the answer is yes. So low impact activities like golf, swimming, doubles tennis, cycling, snowshoeing, cross-country skiing, these are all things that are encouraged and hopeful that patients would be able to resume if they're passionate about. And what happens if something happens, so to speak? If there are complications, if there's an infection, or if there's a dislocation, or something breaks, we do have the ability to address problems if they arise. Sometimes problems are relatively minor and don't require further treatments. Sometimes problems are major and require revision type operations. Hips can be revised in the future. It's not something that we look to do or hope to do, but depending on the situation, it is something that can potentially be addressed. And that is something that we address over here at Mercer-Bucks, whether it's the first time you're having surgery or the second or third time. We're here to take care of your hip in that regard. And so I'd like to thank you for joining us this afternoon. Looking to take a few minutes to answer some questions. All right, so I'm going to start with the first question here. So my background and experience with hip surgery. So my background, number one, is as an orthopedic surgeon. And as it pertains to hip surgery, I'm fellowship trained in adult reconstruction, which is a fancy way of referring to somebody that does hip and knee replacements, complex hip and knee replacements, and revision hip and knee replacements. Hip replacement makes up probably about 50% of my practice. The other 50% is knee replacements. And we're talking about hip replacements. That includes revision surgery, and probably about 15% of my replacement practice is revision operations. As far as age limits, so there's not a hard limit on the upper or lower end of the spectrum. We have an ideal age range for patients that are having hip replacement, and that's usually between the age of 65 and 75. Typically, folks are still very active at that time, don't have some of the major medical issues associated with more advanced age, but not so young that we worry about the implants wearing out. We start to get concerned about longevity of the implants in patients under the age of 50. They have a longer life expectancy and higher physical demands that can be done for a longer period of time. As far as the upper end of on the age range, what's more important necessarily than how old the patient is how healthy the patients are. I've seen very, very healthy 85 to 90-year-olds. I've seen very, very unhealthy 45 to 50-year-olds. So that's really more important. As far as approaches, the approach that I settled on is a posterior lateral approach. In my training, I trained on a direct lateral, the direct anterior, and posterior approach. My reasoning for doing a posterior approach is the one that's it's very predictable to me. I don't have to limit who I can do an operation on. I can offer it to just about any patient. I can use any implant that I want. Patients generally do quite well with that. They don't have really significant pain. They're off their devices within anywhere from 2 to 6 weeks, and my overall complication rate has been low with that. As far as medications that we use, so meloxicam. I have a question about meloxicam. So it's used for arthritis and inflammatory type pain. It can be potentially used for a long time. The use of any anti-inflammatory medicines, it can be associated with gastrointestinal irritation, stomach upset. Patients that have high blood pressure do need to have careful monitoring of their blood pressure. If their blood pressure starts to become elevated over time, then the use of anti-inflammatories may need to be curtailed. And if there is any problems with kidney disease or renal insufficiency, then those medications may need to be more limited. Do you have a question about a steroid injection or a cortisone shot? What that involves is we make an appointment at one of our sites where we have the use of fluoroscopy, which is like an X-ray machine. The whole procedure itself takes about 10 minutes for positioning to get pictures of the hip. The injection itself takes about 30 seconds or so. But we use guidance to basically watch the needle go to the hip joint. All right, I have a question about hip bursitis. That's something that we didn't really talk about a whole lot, but it's something that we see very, very commonly in the office. So hip bursitis is something that occurs when you have patients. Patients will typically have pain on the outside portion of their hip. They may have difficulty sitting on hard surfaces like chairs or laying down at nighttime. So medicines that we use to help with this, again, are anti-inflammatories. There are local steroid injections that we can give in the office in the sites where it's painful. And physical therapy can sometimes be quite helpful for the treatment of bursitis, but also to help with your back. Sometimes folks that have some lower back issues can present with bursitis as one of their major symptoms. All right, so in general, I got a question about advice for general hip pain, more like aching and stiff after playing tennis or very long walks. So depending on how much pain you're in and how stiff things are. So medication-wise, we recommend using a low-dose anti-inflammatory if it's really painful and troublesome. Sometimes I would recommend some moist heat, and that can be as simple as taking a warm shower first thing in the morning, just to help things loosen up. There are some general stretches that we can do in the morning and at nighttime to minimize some of the feelings of stiffness associated with that. And again, I would reserve the medications for if there's pain that's sort of getting annoying and limiting things to do the following day. And in preparation of doing some of those activities, if you know you're going to be playing tennis or going for a long walk that day, stretching well in advance, and sometimes even taking a low-dose anti-inflammatory beforehand can be helpful. All right, I have a question about distinguishing between arthritis and sciatica. So there are different physical exam findings during that we would look at during the office visit. Things about in the history, you know, when are things painful? When are they not? The location of the pain, is it pain in the groin or is it pain in the buttock? Does the pain radiate down the back part of the thigh below the knee? That's typically associated with things like sciatica. Pain in the groin and the inner portion of the thigh are things that are typically associated with hip arthritis. During the physical exam, if there's pain elicited with rotation of the hip, then that can certainly be an indicator that that the symptoms are because of hip arthritis. And sometimes if the exam is not really clear, everything kind of hurts, the groin hurts, the butt hurts, the pain goes down to the foot, an injection can sometimes be very helpful in helping distinguish that. And that's what we call a diagnostic injection of the hip joint, where we're just trying to numb the hip joint and looking to see what degree of pain relief people get. Does some of the pain go away? Does all of it go away? Or does none of it go away? And that can help us narrow down where some of the symptoms may be coming from. I have a question about what offices that I'm located in. So I'm currently seeing patients in our office in Hamilton, as well as our office in Langhorne. I do surgery all over the area. I'll do surgery at Princeton Medical Center, Capitol Health in Hopewell, Robert Wood Johnson in Hamilton, as well as St. Mary's Medical Center in Langhorne, in addition to our surgical center in Lawrenceville.
All right, Dr. Scott, I think you answered all of the questions. Again, thank you so much for taking the time to present this information to us today. It was very informative, so thank you for that. If anyone would like to make an appointment with Dr. Scott, you can call our office at 855-896-0444, or you can also schedule appointments through our website at www.mbortho.com. If you have any additional questions with regards to this presentation, please feel free to email me at programs@mbortho.com. I usually consult then with Dr. Scott to make sure I get the right answers back to you. So I will be sure to get back to you. Again, everyone, thank you for joining us and enjoy the rest of your afternoon.